Hello and welcome to the September 2020 Pre-Hospital Care Research Forum Education Research Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. The PCRF partners with the National Association of EMS Educators to promote research literacy and advance the science of EMS educational research. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Corey, and joining me today are Dr. Kim McKenna and Katie O'Connor from UCLA. We'll have them introduce themselves in a few minutes. And then a little bit later, Bill Toon will be joining us. David Page is traveling today. We wish him well in his travels. The study we're reviewing today is Emerging Evidence Toward a 2-to-1 Clinical to Simulation Ratio, a study comparing the traditional clinical and simulation setting. And this was published in the journal Clinical Simulation in Nursing in 2019. So thank you all for joining us today. We're going to begin, but first we want to remind everyone, if you haven't heard already, the NAEMC Symposium this year is going to be virtual. So some of you may have just recently gone to the EMS Expo virtual conference or EMS World Expo. Well, NAEMC is following up October 6th through the 8th, 2020 with the virtual symposium. You can check it out online and register online at the NAEMC website. So we want to move forward here, and PCRF will have a presence, research of course will have a presence at the virtual symposium, and we actually will have, we won't announce it just yet, but we're going to have a little bit of a news for you coming up about some more research happening possibly in November. So stay tuned for that. We're going to begin. We want to remind you that you can use the chat feature on your screen to type in questions and comments, and then we're going to bring those into the conversation as we go. And if you do have some experience with simulation, or you feel like you have a longer answer or question that you'd like to interject here, just send the organizer a quick chat message, and we will bring you in and unmute you, and we can have a discussion about your experiences or your questions. So a little bit of background here. In all areas of medical education, we know whether it's medical schools, nursing, or allied health programs, sequencing of the curriculum typically reflects the educational theory that the development of competency begins with building the foundation of knowledge, then applying that knowledge, practicing and demonstrating that through various forms of learning like simulations. And then finally, putting that into practice in real life situations, like a clinical setting. This is something that we're familiar with in clinical practice, this type of model that we're looking at here, which is what this study is actually going to be based upon. They used this Miller's pyramid as their theoretical framework. But research has emerged over the last probably more than a decade on the efficiency of use of simulation in the development of competency. Clinical shifts, as we know, and this is even predating COVID. So let's just we know that there's been a lot of problems with clinical displacements and COVID, and which has actually brought this subject to the forefront. But even before then, clinical shift experiences, we know, have a lot of randomness to them. There's a lot of variety for each student, and simulation may provide a potential solution to that randomness by offering a more standardized and structured learning experience. And now, even from that, we know that the nursing field has the National Council of State Boards of Nursing simulation study. There was a large study that demonstrated that simulation can effectively substitute the traditional clinical experience in a pre-licensure nursing education. And I believe some studies had come up with the ratio of 50% simulation you can replace, or simulation can replace up to 50% of the required patient encounters. But so the real question underscoring all of this is, our traditional clinical experiences, are they actually providing the students with the learning that is going to be necessary for good practice, and then ultimately for optimizing patient outcomes, which is that, translation level that's way out there. So this study itself had 2 research questions. They wanted to really tease apart the activities that happen in each of those settings, because we do have a tendency to really kind of hold on to this clinical experience for good reason. Well, this is the reality. This is what you're going to see. These are patients whose skin color changes, and who have social issues and other things that surround them. And does simulation actually help with that or not, or can it replace it? So we do kind of cling to that notion, but we've never really taken a close look at comparing the activities that go within each one. And from an educational perspective, we also want to look at the time it takes for the student to achieve that competency within each setting. So the research questions here were, what are the differences in the number and the type of activities that were performed in each of the settings, in a clinical setting and in a simulation setting? And then the second question was, what are the differences in the time spent in the learning activity, the different types of learning activity in the clinical versus the simulation setting? So this was an observational, descriptive, and mixed method study. Although the data that are presented in this paper don't include the qualitative results, they actually make a statement in there saying that they're going to be presented elsewhere from the qualitative surveys. This was observing the activities that students take part in each of the settings. So it's the theoretical framework you can see is Miller's pyramid of competence, which is very common, commonly used in health programs and clinical programs. And you can see on the right side, that we actually have it on the screen here, this slide that shows that the base of this is the development of your cognitive domain, so basic knowledge, and then application of that knowledge through analysis of cases, and then finally the behavioral changes, the demonstration of learning through simulation, and then finally at this peak of the pyramid, performance integrated into practice, so things that we think about applying it into a clinical setting. And then all the domains, of course, are looked at: knowledge, skills, and attitudes, and then from moving again toward competency, or even in this case, they're showing it towards expertise. We're in initial education, we're usually not looking at toward expertise, but this is sort of the theoretical framework. So I'm sure, Kim, you're familiar with the Miller's pyramid, having studied, educational theories. And actually, let me take a minute and have Kim and Katie introduce themselves, and then we'll start talking about the methods here. Kim, you want to start?
Hi there. Yeah, my name is Kim McKenna. I am Director of Education at St. Charles County Ambulance District, which is in the Metro St. Louis area. And I'm super excited by this study because it's really, like Megan mentioned, it's really come into the forefront, and not only locally within my little world, trying to get our EMT and paramedic students through in the era of COVID, but even at the national level, there's a lot of discussion about this. And so this paper is very, very timely, and I'm really happy to see it.
Thanks. Katie, you want to introduce yourself?
Hi, I'm Katie O'Connor. I'm the Director of Simulation at the UCLA Center for Pre-Hospital Care, and I echo Dr. McKenna's sentiments about being really excited about this paper. Super timely in COVID, but also just something that everyone's been talking around or about for a while now. So it's really great to see us examining it, looking at it in a research perspective.
Great, thank you so much for both of you for joining us, because now we have some depth of knowledge in education theory, and also in direct practical application of simulation. And again, if you're out there and you've had some experience in simulation, or maybe you've gone through the certification, you're, what do they call it, cheesy certified, then maybe you'll have some knowledge to add to this as well. So in order to address their research questions, I'll just go through the methods, and then just a brief overview of the results, so then we can get to what we're, the bottom line here. So this was a study done and I believe it was Maryland. They didn't say it in the paper, but I read it. I actually followed a thread from one of the researchers, and I believe it was done there. But it was 3 pre-licensure nursing program, so 3 different institutions. It was over 3 semesters, and it was a convenient sample of 63 students that initially, before some exclusions, that were participated. They were consented. This was IRB approved. This was med surg, pretty much students only. The class was either basic or advanced med surg, as you'll see, a lot of basic med surg. And then on the day of observation, they were randomly chosen. The student was randomly chosen for observation. Now, they only observed the student once. So you were either observed in simulation if you were a participant, or you were randomly selected to be observed in clinical. So it wasn't matched. It was not, it was a random selection of an individual student, and that student was only evaluated once in one or the other settings. And then they had a data collection tool that they used that was standardized. So they established that ahead of time and had some data points that they were going to be looking at. They had activity categories, for example, medication administration, physical assessment, teaching, and not the teachers teaching, but the students doing student teaching of patients, because this is a nursing program. So teaching is part of the training. And then documentation, safety interventions, and communication. And then they determined whether each one of those categories, whether the student was performing independently or whether they were supervised. And some of that relates here, as you move toward this competency, then you are, more and more independent. So it relates to this Miller's pyramid. Then they used a coding system to code each of the subcategory activities as to whether or not which part of the pyramid they were on, based upon how independent the student was and based upon the observed behaviors. So they coded this 4 times. They had an initial coding by the observer, and then they have had a collaborative coding, and the research team review it. So they had sort of 4 layers of coding. And only if the activity had a direct impact on patient care did it get Miller coded. So you have sort of 2 elements to this. They wanted to, first of all, describe all the activities and how much time it took for each. And then they took only the ones that would have a direct impact on patient care, and they Miller coded those into this pyramid and put them into a category of either knows how, shows how, or does. And they also used a survey tool to, ask the students how it went. But again, that was presented separate from this paper. I actually looked it up to see if I could find it. I couldn't find the paper that had the survey results on it. But I did find something else we'll talk about later. So ultimately, so this is your table 1, which shows you the sites that they had. They had 21 hospital clinicals, 21 simulation observations. And so these are the 3 different sites. You can see they have a larger site that had 2 cohorts, but the cohorts are approximately, anywhere between 60 and 140. You had large cohorts of students. The clinical group size is almost exactly the same. It's probably standardized. I don't know if these were accredited programs, but they were 8 to 10 in the clinical group size. And you can see they were med surg largely, and an academic center was the one that had the larger one, and really medical surgical floor types. So this table 1 just tells you kind of a breakdown of the different sites and the different types of activities. Incidentally, they don't mention it in any of the schematics, but in the body of the paper, they mention that the highest activity of at the clinical site was between 7 a.m. and 11 a.m. And I'm sure those nurses out there are saying, yep, that's definitely the highest amount of activity. That's when the handover reports happen. That's when the repeat vital signs and the care happens. So that was something interesting to note for later evaluation. And then in the simulation setting, 66% were mannequin based versus standardized patients in the other, whatever that is, 34%. So then you see the schematic of observational activities, and this is the observations of these are individual activities, and you see that in the next table. You have 21 simulation, 21 clinical, and the clinical you have a larger number of hours observed, which isn't very surprising because we kind of know just from teaching that the clinical setting can involve waiting, established hours, right? And you have established hours in a clinical unit. So an 8-hour shift times however many 8-hour shifts. And then 27.4 hours observed of the simulation. So, that wasn't too surprising. And then the number of activities that are actually observed in each, you can see here 1,500 plus activities in the clinical versus 379 for the simulation. And then about 1,600 of those qualified for Miller coding, and you can see the branching off of how many were evaluated for Miller coding. Okay, and then in table 2, they show you in simulation versus what we're seeing here is simulation versus clinical here, or not necessarily versus, but side by side, we're seeing the activities that occur in simulation and the activities that occur in clinical, and what percentage each one was of the total activities within each. So what percentage of time did students in clinical spend doing, for example, this first one, chart review? And the same thing for simulation, we see that. And then next to that is the number of minutes that were recorded and the total time spent within all of these activities, the total time spent in that activity in this setting, and the same with the clinicals. So Kim and Katie, what do you think? I mean, when you look at this table, the authors are looking at it and saying, you've got simulation, the big thing that jumps out is more activities in a shorter time frame, and then a couple of things that stood out to me that like the documentation piece actually stood out. I'd love to know what you thought of this table and some of the things the authors found.
I feel like it validates my experience personally. I know that I spend a lot of time trying to figure out how I can incorporate documentation into our EMS sims because I'm like, they just won't write anything down. They won't like put it in the EHR, and then they get to the end and they're doing their like hospital brief and they like just turn back to you as the facilitator. What was that blood pressure? So it just, this table, like there's one example, it's just highlighting like, like things that I don't do in sim or that I would like to get into sim are not being shown up. And then same thing, like things that they do in clinical or that they complain about in clinical is what's showing up. So it seems to like validate my experience, which makes me like happy because I'm like, I'm not crazy. That makes sense.
Kim?
I think it really underscores the efficiency of simulation, like how much you can accomplish in a really compact amount of time, and how it's a planned experience, that there was a statement in here that says, in clinical, every student gets a unique experience. We can't plan for a student to have certain things happen. And this just really underscores that in the simulation, you can really plan for things to happen.
Yeah, and I think that's how it's been used. Just this is from my experience and talking to others, is we've used simulation to fill the gaps in clinical. So we've said, okay, we're going to make our best effort at getting you a live delivery. We're going to send you to labor and delivery, and you went through one 8-hour shift and you haven't really seen anything. We'll send you to one more, and there's 16 hours that a student has had a lot of downtime. Really, really glad they measured all these details of downtime, by the way. And then finally they say, okay, in our policy, if you haven't seen a live delivery, then we're going to simulate it, but we've made our good faith effort. And in paramedic programs, I think those of us out here, looking at things like Appendix G and trying to implement a competency, model in our programs based upon the basic skeletal structure of Appendix G and say, okay, this is our sequence, we're going to develop competency, but we have to develop policies around that say, okay, if we say you have to have 3 live intubations or 10 or whatever it is in the OR, but you've gone, let's say 3 times for 4-hour shifts, that's going to be our that's it. That's the maximum you can go before we say, all right, now we've got to do a simulation to live ratio. And that's something we talk about a lot. I know Pat Tritt and has published on this, some really helpful things on it. And we've talked a lot about how to establish a kind of standard, or is there a standard? Is it more programmatic? Is it something we work on with our community advisory committees? And, these are great kind of things to bring up. But that ratio of skill to live is a very big topic right now, and has been actually for a bit in paramedic programs, and related to accreditation, I would say, but also just related to practice. So yeah, I think Katie said something that really hits home, which is it validates what you're thinking. And also I have written on the paper in the side, boy, this is one of the real weaknesses of our simulation, and that is documentation. We're not practicing documentation enough. And, that's something that probably, I would imagine, that bleeds over into field internships and initial field experience too, is the ability to measure how the student is documenting. What did you
Actually,
think?
I always tell the students that's really how your new employer is going to evaluate you, is on your documentation. And so I agree, it's a weakness in our program, and it's an opportunity, like Katie said, to be able to incorporate it somehow into simulation as well, to be able to, because you would be able to monitor exactly how accurate the documentation is because you've programmed the scenario.
Yes, and Bill Tuna is just joining us too. And Michael Kirk just made a comment that I love, and this is something we've been trying to do in our program too. Is he says one thing I do is to push documentation, is to use FISDAP to chart everything, practice or real, and then I use those reports as records during legal lecture to highlight why it's so important. What a great idea, right? Wrapping it around. So using your program that you use to document in the lab and sim lab itself, whether it's FISDAP or other, and then wrapping that around to your classroom. So Bill, can you hear us?
Oh yes, I've been listening to you guys yak
Great.
away.
And thanks for joining us. It's good to hear. I just think about the practical. This is a very pragmatic kind of application to this study. Just that, I mean, when you look at these individual activities, I think every one of us who's run simulation or has been to clinicals with students can relate. I would say one of the things too that stood out to me was the safety interventions. So if you look at the clinical activity and where time was spent, we're talking about chart review and information gathering, but safety interventions too. And that stands out to me because we've talked so much about the EMS culture of safety. Yeah, what did you guys think of that? That was one of the areas that we saw.
Yeah, I wasn't really sure exactly what they meant by safety interventions, but I could see how, like, you can program in the EMS world. We always do that, and I know you talked about it on the last webinar. Scene safety, BSI. But in the simulated setting, you can program in unsafe scenes, and then really in the debrief really talk about, like, why didn't I see that early? What could I do to alert myself to this unsafe situation? So I wish I had more in the qualitative information. They might have more information about specifically what those were.
Yeah,
Well,
one of the things they mentioned in the paper too was hand washing, which to me, and from my experience teaching in the nursing program, and then in EMS programs too, I think they do a better job than we do. We tend to have like a jazz hands approach to scene safety and BSI. Like if you wave your hands in the air, all of a sudden you now have BSI. And the EMS perspective really focuses on protecting the EMS provider. And we do a really terrible job of safety interventions like sterile fields and like protecting the patient. So it's great to see in nursing simulation that they really seem to have captured that. Like, hey, you should wash your hands for the patient's benefit. Like you need to make sure you don't break sterile fields. I get it. We're in dirty ambulances in people's living rooms in the street, so we don't really have sterile fields. But that's one that to me seems like, wow, they're doing it in clinical, they're doing it in sim. I don't think I'm doing it in EMS. We probably need to be doing a better job here than jazz hands.
Well, I thought was really good is when they talked about it, they were able to see it in the clinical because students could go from room to room or in and out of the room. And every time they left the room or entered the room, they had to clean their hands. And then they talked in the simulation, well, you usually all stay in the room, you don't leave. It showed the difference between the simulation versus what it's like in the actual clinical practice. That's where they really touched on that. And again, I think Kim already mentioned is that it needs to be truly programmed into it. And I think that was the neat thing I saw in this paper is, to me, it actually showed gaps in simulation that need to be improved, but it also showed gaps in clinical that need to be improved. And I thought that, to me, was really beneficial. But I do agree. I want to make sure I understand. Simulation, I think, needs to be here in the future. And I like the fact that they're trying to create what the ratio needs to be, simulation to actual clinical. And I think I still am a firm believer you need both. I don't think we can do it without both components.
Right. I agree. I want to go back to something that you said about safety. When we did the simulation, the super simulation study, and we asked about objectives for simulation, patient safety was, and even EMS provider safety, that was one of our lowest responses that we got. So I think that's an opportunity for folks that are programming sims to make sure that that's in the objectives, and specifically which of those safety objectives you're trying to achieve, so that you're bringing it out to the forefront.
And I think to me it truly is important, because when I've had opportunities to watch more in the field than actually do, and it is really amazing that simple things like covering patients, strapping them effectively, putting the side rails up, and then just how people cross-contaminate with gloves and everything, and just they're doing it in the field because they've never really had it structured into them. And I think we need that is, to me, a lot of safety related type stuff. So I think we need to find a way to improve on that. And again, that's from personal experience. I can't say it's from an actual study.
I would love to see a comparison using the same table here of paramedic students in simulation versus clinical. And in particular, I'm looking at the activities, the types of activities that are measured in simulation here versus the clinical. But looking at, I think the number of skills or number of minutes doing skills in simulation, it seems really low to me versus, when you compare it to how long is spent on pre-briefing, debriefing, post-conference. That actually stood out to me as something that it's a pet peeve of mine, and I'm sure Katie can comment on this, that faculty, and we'll get into faculty too, but spend a lot of time briefing and debriefing and intervening in EMS simulation, at least. Nursing and versus EMS simulation, nursing has spent so much time on applying theory, and they've established a profession around education and nursing. So that part stood out to me. Katie, what's your experience in terms of this element here, pre-briefing, debriefing, post-conference, as it relates to paramedic? This is nursing, so.
Yeah, to be honest, I feel like in EMS, we still, we're doing simulation, we do scenario-based education, we do skills training, but we don't really know what we're doing, right? I don't think that the concept of pre-briefing as described in this study and what most people in nursing simulation would say, we probably don't do. What I see was they go into the room with the paramedic instructor, and the paramedic instructor gives a mini lecture on the skill and then shows them how to do it, as if they never had that content before, right? So I wouldn't call that pre-briefing. It's almost like it's a little mini lecture beforehand, and they do so much talking, and then you got like 10 minutes, and they're like, okay, quick, practice this skill. Okay, that was great. You guys did wonderful. And then just move on. So it's strange for us. It seems like we have many teaching sessions instead of like actual pre-brief. I don't know if that's your experience, but that's what I've seen.
Yeah, that has been mine. What do you guys think, Kim, Bill?
I think it depends a lot on the instructor, to be honest with you.
Mhm.
And yeah, letting them, it takes a lot of conversation to let them just run without a lot of intervention, and then really talk about what were you thinking when you did that, and those kinds of things. And it does take some a coaching of the instructors to really get the most out of the debriefing part of the scenario, which I think can have so much value. It's sort of like that back step debrief that your preceptor should be doing when you're in your field clinical experience, which is why I think that, well, we'll get to this later in the paper, why I think that, you know, the higher level skills were so low in the clinical area, whereas in simulation, they were able to achieve some of those. Because I think in the field clinical setting, we can achieve some of those in EMS too.
Yeah, I would agree. And I think you hit it on the head with you know, faculty variability too. And that's, I think, one place we can discuss in a little bit. But I'm reminded of that saying, practice makes permanent. So one of the things, you know, instead of practice doesn't make perfect, practice makes permanent. And that's, you know, one of the things in simulation that's kind of a side effect is if we can teach bad habits into students as well, if we allow certain things like the jazz hands for scene safety instead of actually practicing it. We have a couple of comments too. For our EMS sim, we incorporate medication cross-check procedures. That's from Stephanie Ashford. So that's exactly feeding into what we're talking about, is trying to develop good habits before hitting the real setting, or even during, you know, going back and forth. It actually, I've heard of people using it as a remediation method as well. So if somebody goes out into their clinical setting, or they go out into the field, a paramedic student say, and they make a medication error, you know, under the supervision of a preceptor, but say they make a medication error, and the part of the remediation plan has been to repeat certain things in simulation, so that practice makes permanent, safe practices. Another comment from Daryl DiMartino is, do you think we focus on some of the wrong things in EMS simulation? That is, skill versus leadership or call type rather than encounter? What a great question. One of you guys want to tackle that?
Oh man. Yes. Yes. All of it. You think some of the things that we see and is that, like, you can just go to like backboarding and stuff, right? Just looking at that debate over the course of time and seeing that, like, oh, we took a kind of good idea and just applied it to like every possible situation ever and practiced it on our EMT students and paramedic students, who all tend to, at least for the majority of them, I would say it's definitely not a bell curve distribution, healthy, young, like men with no need for padding, really, compared to the patients that really are the ones that need the spinal ones, that are like older, you know, patients with kyphosis, or definitely need padding, but we never practice that way. And we never practice with padding. And then we developed this like problem where we were not padding patients and causing more harm with these backboards. So for sure, I think some of the things that we focus on, like time on scene, is the most important thing. So just get that backboard on as fast. I can remember even doing like splinting races and backboarding races with my students, and looking back on it, it's like, oh, what was I focusing on? That was definitely the wrong learning objective.
Yeah, and I think Daryl hits a point too. There's another thing that isn't, you know, there's an entire encounter, when he uses the word encounter rather than you know, a call type or a specific thing. That's where all of the things that go around a patient's scene, you know, whether or not there are some issues on the scene, psychosocial issues, or, you know, other things that you have to think about, an entire patient. I think that whole patient view. Ron Lawler also hits something that we have talked about here that I think is really important in EMS education, is we need to stop thinking about teaching skills in a separate place, like these stalls of, mannequins and instructors where someone walks up and says, I am starting an IV, jazz hands, here I go. And just incorporate the skill within the simulation, so it becomes about this entire encounter. And I think he's absolutely right, because the way that you build all of your habits into that is, you have to think about cognitive load. I understand we talk about that a little bit. Is it too much for a student to do that at some point, at too early, to try and start an IV and use all the safe procedures within a simulation? But I think the faster you can get to that, the better off you are to build better habits. So
Yeah, Megan, I think like the thought is walk, crawl, run. I've heard that a lot. And you're making the point about cognitive load, but we need to kind of adjust the idea that walking is doing an IV attached like to a person, not to a disattached arm. You never
yes.
ever will do an IV to a disattached arm. Why are we training that? The walking should be an arm on a person, a human. That's the first step. The running is an arm attached to a human who's just been shot in low light while people are yelling. That's the run, right? Not run shouldn't be a person, right? Our walking should be the person.
Well, the other thing in here is, what is driving simulation in paramedic programs in particular? And some of that relates to where they're headed. They're going to be tested at National Registry now using the integrated out of hospital scenario. There's, where is the requirement? What is being driven? Because we are usually very requirement oriented, right? So if I think the integrated out of hospital scenario increased the amount of simulation in paramedic programs, because we have to prepare the students to actually be able to graduate and get their license. So in order to do that, we better start training them in the integrated out of hospital scenario so that they can move to the next step. So, it's sort of an effort. It's kind of working backwards. But would it happen if we didn't have that? Would some programs just say, okay, we're going to do, the skills that are, I'm really, happy we don't have to send them to do intubating heads and, and starting IV arms on little rubber arms anymore, which was silly, and having that pushed back into the program. So that was a good idea. But what is driving that? I think that's really important, because programs are going to, why do we incorporate simulation? What is making us do this? And I think part of that is the National Registry requirement. I don't know. What do you think about that? Why else would a program do simulation? Besides the goodness of their heart, right? And they have so much money to spend and lots of dedicated time, right?
Well, you sort of started to dance around something that I think that is really important here, and I know that the other two, Kim and Katie, both have the experience in this, and we discussed this in the past, is EMS is often, education is funded and staffed on the cheap, is the term that I like to use. And when you typically look at places that run full-time simulation labs, they have a core staff of people who just maintain the simulation equipment. They do all the maintenance on it, they do all the cleaning on it, they do all the resupply of the rooms and everything, and then you have people that are specifically trained to do the scenarios, that know how to do sim scenarios and debriefings and everything like that. And that is a unique staff. I think very few EMS education programs have that kind of depth that they could also be able to do that. And I saw Pat Tripp's comment in there too, is there's lots of external forces that are causing us to look at simulation. So do we need to step up and make the commitment?
Yeah, this is opportunity.
Daryl DiMartino is making just the point that you just made, that, as EMS instructors, how many of us really have formal training in simulation, pedagogy? And the answer is very few. And not many programs have the luxury of having somebody like Katie that's, really dedicated to simulation, that has the training to do it. And so that's where it's hard to compare the nursing studies directly to COVID, directly to EMS, but I was going to say, but COVID is driving that discussion forward now because people have had to simulate things that they never thought they were going to have to simulate, and the states are allowing it. So it'll be interesting to see outcomes after this.
Yes,
Yeah.
and
Oh, go
go
ahead,
ahead.
Megan. I was just going to say that, like, Megan and I have been on calls with the state trying to convince them that there's more to simulation than just a mannequin that's fancy.
That's
And
right.
just in EMS, we don't even really understand what these terms mean or the different ways you could do it or the different, modalities. And that's kind of hampering us, because if the EMS agency, the state regulation says simulation is a mannequin with 10 pulse points, then people are like, oh, there's no way that I can do it. And you're like, yes, you can. You absolutely can. You can do it with like a baby doll. It's about the communication with the patient. It's about the teaching, the different things we're seeing here. There's so many categories of things that you can do. You can do teaching, documentation, safety intervention. None of those involve a mannequin that has 10 pulse points. And so it's just our thought process around this is problematic.
On the
Yeah.
flip side, though, it's also causing us to have the discussion that's really made in this paper is, are clinical hours by themselves, what do they really represent? Are hours everything? That in Missouri, it's a big topic of a discussion right now. And, this paper would suggest that hours aren't everything because, as Megan pointed out earlier, they analyze the amount of time that the student's really not doing anything.
Yep.
But meeting that time requirement, they're doing that, but they're not really doing anything that's going to further their learning.
Now, the total downtime is just like fingernails on a chalkboard to me. Especially, I was actually kind of surprised in the simulation because I think in EMS we've had this problem, and hopefully people have been resolving that in their programs. Is having people sort of stand around to wait to run a simulation or something is highly inefficient way of doing simulation. And again, nursing has gone is much more advanced for us. And yeah, simulation as a replacement for clinical is really the point of what they're trying to get at. Is there a magic number? Is there a magic ratio of simulation that can replace clinical? But also the question of, what is the value of the clinical? I mean, and not really what's the value, but what about the hours? These hours and this time spent on clinicals.
Right. Well, the FISDAP research forum, almost every year, somebody does an abstract that shows when they compare clinical to field experience, and they look at the ability of the student to be able to answer critical thinking questions, that in field, the answer is yes, this really helps with your critical thinking, clinical decision making. But in the hospital, no, it doesn't. In almost every study that they've done, they found it doesn't. And in some cases, it impedes it. And so this also sort of, when you look at the number of lower level sort of skills only, directly supervised, step-by-step procedures they're kind of doing in clinical, this really supports what the FISDAP abstracts have been saying for years.
Yeah.
I think a lot of people are saying too, it's dependent on the instructor, and that I think that's really clear to all of us. But what you're saying too makes sense. I know that students come back from clinical, the paramedic students, and are like, hey, I saw this at the hospital and I'm not sure why they did that. And they're never asking, it seems like, the hospital staff. So it's almost like they're observing things that they can't figure out how to place into their brain, and just coming to their own conclusions without somebody to help them, guide them through that process. And one of the things that nursing does better than us, I think, is they have actual clinical educators on site, so they could do some of that higher level stuff. But when we send paramedic students to the ER, it's whatever charge nurse tends to be there, happens to be there, they get assigned to somebody, but they mostly go around doing skills, not having anyone to really talk about the clinical experience with and do those critical thinking.
So Katie, you hit the point again. This is why EMS education is done on the cheap. And I have two firsthand experiences with this. When I ran a paramedic program, I hired nurses at their time and a half rate back in the mid 80s to the early 90s. And they would go in and do the actual supervision, one-on-one supervision of the student. And they were able to prevent downtime. They were able to move students to see things that were important. For example, if a STEMI came in, they were able to take the student right with the STEMI patient into the cath lab, up into the ICU, and we were able to keep shorter clinical hours, but we were able to increase the amount of experience that the students had. And we also only put the students in clinical areas when there was high volume of patients. For example, students didn't do overnights because we knew there was no activity at overnights. You know, so students were limited to even when they could go because we moved away from hours and focused on skills. And then for continuing education, we had an operating room experience where we put educators, EMS educators, in the operating room with employees that were coming through the actual to do the teaching in the operating room to take the burden also off the staff. And it can be done, but the problem is it's expensive. That's the downside to it, is that it can be done, but it requires an immense commitment of expense. And I think what we're trying to find here is where is the best return on our investment that we can prove helps us graduate competent entry-level providers. That's where we need to provide the answer to our problems. Sorry, I'm sounding like Dave Page on the soapbox.
Thanks, Bill. Ron reminds us too, and he was part of this study and the FISDAP research summits that you were mentioning earlier, Kim, that lab experience was beating the hospital clinicals too in terms of the quality of the experience, and that's what, and the outcomes, you know, from the numbers of experiences in simulation and in lab, and number of patient contacts in a simulated setting. So looking at this final figure here, this was sort of the bottom line. They wanted to take what are the qualities, not just the numbers of activities that they're doing and the percentage of time spent doing the activity, but what's the level of learning that's happening within, level of, you know, competency that's they're observing within each of these activities. And they chose, you know, activities, as we said earlier, that were most likely to affect patient care. And you can see the results as they kind of put them onto the pyramid, that students in simulation perform more time in the knows how and also in the does category. They function independently in both settings, but in simulation you see a much more efficient use of time, 66.3% of the activities occurring in 440 minutes versus the clinical 46% of the activities in, you know, over 2,000 minutes. So you can see that it's not just the number of activities in each and different spread of activities and the amount of time, it's actually the quality of the time spent. So this, I thought, was a really unique way of looking at it. And to me, it underscored something else, and that I think I started looking up this primary author to find the subsequent research, and found instead a paper that was published earlier this year that is on the use of education theory and standards to drive simulation-based education, and a curriculum to train the trainer in nursing. So as we've all been saying, you know, nursing has really advanced the science around education in simulation and in clinicals. And we have a long way to go, but I think that, you know, having this conversation is step one. You know, having organizations that are committed to education, you know, is part of that too. And having a national system of accreditation and all of these things that can drive things forward. But yeah, I think that the use of theory and standards in simulation-based education and in EMS education in general is something that we are striving for. Wouldn't you agree?
Yeah, to me, I think one of the things that's like we mentioned that accreditation is great, but then we have like Appendix G, which has a table 2 that's just kind of nebulous. Like, it doesn't really explain to people what column 1 is, what column 2 is. What does comprehensive mean? Like, what is formative? When you look at nursing, they have like the NASCL standards, and it's like a 12-page document kind of explaining all of these things. And we don't have to reinvent the wheel in EMS, but gosh, we could at least link to things like the simulation dictionary or the NASCL standards to help people have an idea. I mean, like Dr. Toon says, we do it on the cheap, which means that, hey, you're a really good paramedic. Why don't you come for like a few dollars an hour, teach people? And that's kind of like your introduction to being a skills instructor. We could at least start using some of these definitions and some of this education that's come out from our colleagues in healthcare.
Yeah, and I know Pat Tritt is on the is one of the listeners out there, and she's worked a lot on this and posting up, I believe, a simulation dictionary on the COA site, but linking that to, like you said, I think that table 2 it's the everyone's interpreting that a little bit differently. And if you interpret it just at face value, you might think, okay, I need to do this, and then I do this, and then I do this, and then I do this. It's that sort of sequencing that, it seems like you must have before you go to the next level. And I think that's what we're talking about here. Is it's really not that way. You can mix things in, and you can go back and forth, and it's not that simple, and it's more focused on the education theory and the use of some of the standards to drive it. So any comments from Bill about just where we should head in terms of faculty education? I mean, more
Well,
cheesy
no,
certifications.
No, but I do like the fact, and it's a good thing that the NEMSI just published their position statement on EMS educators. What degree requirements they should have based upon what level of provider they're educating and what type of people are doing what. And I think that's certainly is a step in the right direction, is to be able to look at ourselves as educators and how can we improve not only ourselves but the future market of educators. And clearly a component of any future EMS education needs to be simulation. And what does simulation mean? Everywhere from program patients to sophisticated mannequins, and what are the terms and the definitions, and what are the outcomes? But I think there is the need for the research, and I've heard us sort of dance around this a little bit, is we need to find out if we can do it in a simulation, can it have a positive impact in the field? And that has always still been, we haven't found that magic way to link what we are doing in education to what our graduates actually do with patient outcomes, and how does it impact patient outcomes? That would be the ideal study. And anytime I state real studies, I also know the shortcoming is who's going to pay for it? Because to do a well-run study costs money and then personnel to be able to do it. But we do need to get to that linking, is how do we improve EMS educators? How do we do future EMS educators? And then also, how do we prove what we're doing in simulation is having a positive patient outcome?
I agree. And I think that, a couple of people, I don't think we can directly, obviously, compare ourselves to nursing because we have that whole field experience. And both Daryl DiMartino and Pat Tritt made the point that there are some skills that we rely on in clinical, like being able to talk to patients and being able to do skills that if they're in the field at a slow pace, they're never going to get a chance to do those skills. So I think there's not always a one size fits all in EMS because of the variability of our experiences. But I mean, I do agree that we need more research to be able to find it out, and it will take money to be able to do that well enough for us to be able to make conclusions, because the whole hours thing has and direct hours has become a big issue right now. So
yeah. Well, I think the quality of the clinical is a real issue and a big question mark, right? So how do we usually measure it? In numbers? How many IVs did you start? How many med administrations did you get? 12 leads, patient assessments, patient contacts of different, numbers. But like Pat says too, in here, it's about learning to talk to the patients, and like you mentioned, completing assessment, getting histories. And I think that can be simulated well too, but I think that it can be simulated so that you can practice how to do this, so that when you go to a clinical setting, you can even build on that when you're looking at someone who actually has the condition. So, they always say that, I always compare simulation practices to aeronautics. And in NASA, they always say, the first time you actually do something for real is when you're in space. You don't get to, so all we can do is simulate it. But the big difference, they say, is, they'll throw everything at you and you really feel that stress of simulation, but you're not going to die in the simulator. And I think that's kind of the big difference, is we know that the patient is sick and can die in the clinical or field setting. We know the simulator, the sim man's not going to die, or permanently at least. So I think that's a valid, point to make, that of course there's need, but what's the quality of those experiences? And then the other thing that has come up here is, how much of the clinical experience should be in a hospital versus a field experience prior to the field internship? So that's another piece of it too.
I think, Maggie, you bring up some really interesting things about stress and for the student. And one of the things that we are kind of framing the conversation is, simulation can be used to replace clinicals if we don't have access for COVID, or we can get more done in more time. But I think one of the things we really should be reframing is that simulation can reach different objectives and actually prepare people to be better suited to clinical. So we can simulate difficult conversations in a safe learning environment where a student has the psychological safety to make a mistake, so that they're more willing or more likely to engage a patient in a clinical setting versus staring at the chart and doing chart review for the whole time they're at clinical, and then just going in and talking to one or two patients, especially when we're thinking about like EDI issues, where maybe a student in clinical is only going to choose to speak to patients that they feel comfortable with because they don't know how to speak to a person of a different race or a different age range or a different gender or a different gender identity. We can do that in simulation prior to sending them to clinical, and then maybe make the clinical experience more rich for them or more engaging. And it's just things like that. Like we're looking at simulation as a solution to a problem we can't get stuff done in clinical, versus maybe we should look at simulation as an augmentation to clinical and field to make those experiences better.
Both.
Nice. Yeah, nice.
I think it's both. It's
preparing
them, and it's also for those things that we can't do. But Katie, one of your points about with simulation is one of the problems I think that we run in simulation is when we often conduct it, particularly when we're using program patients, we have someone who's 21 years old and says, I'm a 65-year-old man. How many places go out and actually get people that are age appropriate and maybe even disease appropriate to be able to do it? And that really enhances.
Share your Zoom number with everyone so they can Zoom you in as a patient.
Okay, now we weren't going to discuss the age issue here, Katie. But I mean, when I went to a program many years ago at Children's Hospital. It was called the PEM-STEP program and they actually, for our special needs day, they had arranged for parents to come back in with all different kinds of children that had special needs for us to assess and do vital signs on and talk to the parents and everything like that. And boy, what a powerful experience that was, in the sense of, preparing us for not only teaching about dealing with special needs, but also just even as a practitioner.
Yeah. Well, I think we're almost out of time here, but we have we could just keep going on this. But you lifted a statement right out of the paper there, Katie, and Bill, extending that in simulation, the student can practice independently in a safe space. So that's one of the perks of simulation. Pat reminds us that choosing the clinical site for the volume of patients and not the hours is really important, because you can see a large number of patients at a clinical site that you may not be available in the field. So that's, and again, without measuring this, we're not going to know this. So this would be an interesting thing, is go into depth and observation of clinical experiences in different programs. So the one last thing I wanted to mention, though, too, and I thought of you, Kim, about this. What did you think of the whole statement that an observational experience, they did not collect the student observational experience, but they went on to say that it's too bad they didn't, because there's been studies that show that the hands-on role versus the learners assigned to the observer role, that the hands-on or the observers actually showed an improvement in learning outcomes just by observing. What did you think of that?
I think it just underscores the work on peer evaluation that's been done, because they said that especially if you give them a structured thing to evaluate, then that's really going to enhance their knowledge. In some cases, the peer learning research has shown that the person that's doing the evaluation of their peer will learn as much as the peer does. So I think that was a little piece of the study that is an opportunity for more research, quite frankly.
Another great paper. Did we just lose everyone or what?
I don't know.
Sorry, I think I pressed my button, my cough button, sorry. Now this just the final conclusion of the paper, saying that it would suggest a 2-to-1 clinical to simulation ratio is becoming more supported in the literature. So for nursing that is. So any final thoughts? All right. Well, thank you, everyone, and thank you, Pat, for chiming in, and for Kim McKenna for joining us, Katie, and of course, Dr. Bill Toon. And we will be back next month, Friday, October 23rd, 2020 at 10 a.m. Pacific, noon Central, with another PCRF Education Research podcast. But we'll be back sooner than that for the clinical podcast on Monday, October 12th, 10 a.m. Pacific, noon Central. And if you would like to present an upcoming article or join us on our panel, email David Page at dpage@emsed.net. Thank you all. Have a good day.